Welcome everyone to the first webinar in the new series, Methods for Global Health Equity. And I'm Élisée Nouvet. I'm an assistant professor in the School of Health Studies. Today with Leanna Matthews from the Canadian Coalition for Global Health Research at Western, I will be your host. And the purpose of this series is to advance discussion and critical reflection on how we do global health work, with an emphasis on creative strategies for enacting equity. So how we work in global health is as important as the topic or end goal of our project. The processes and our relationships is as important in terms of ethics and in terms of impact of the work. And that is really at the core of the series. So each of our webinars, and I'm very excited for our first webinar today, is going to invite a team to pull back the curtain on equity considerations and practical decisions informing their use of a particular method in the field of global health. The webinars are being recorded and you'll be able to find them on YouTube as well as on the Canadian Coalition website. And you can also obtain a certificate of attendance and participation. So details on that will be posted to the chat. I want to, before proceeding any further, do a land acknowledgement. So building relationships with and towards Indigenous communities is an important value across Canada and at Western University. And acknowledging where the university resides and where I reside is part of upholding the Truth and Reconciliation Commission and their calls for action regarding reconciliation between Canadians and Indigenous people. It's about upholding those recommendations, but also, of course, paying respect to the original peoples of the territory upon which we are physically located. And it's also a means of expressing and normalizing commitments to building relationships with and responsibilities towards Indigenous communities. So I myself am born on Algonquin territory in Ottawa. I'm speaking to you today from the city of Hamilton, traditional Anishinaabeg, Mississauga, Haudenosaunee, Neutral, and Huron-Wendat territory. And on behalf of the Western community, I would like to acknowledge the presence of the university and London on ancestral lands of the Anishinaabeg, Haudenosaunee, Lenape, and the Attawandaran peoples, as determined by the Dish with One Spoon Treaty. The land continues to be the home to traditional Indigenous peoples as contemporary stewards of the land, but also as critical contributors to the Western community and society. So with that, I would also like to say that because this series is a collaboration between Western University and the Canadian Coalition for Global Health Research, I've invited the Vice President of Research, Jackie Burkell, to say a few words, as well as the National Coordinator for CCGHR, Charles Larson. So I will pass the floor over to them for a couple of minutes, and then Leanne Matthews will introduce us to our incredible speakers for today. So Jackie Burkell, over to you.
Okay, so first of all, I have to say I'm the Associate Vice President. While I appreciate the promotion, it's unwarranted.
Oh, sorry, yes.
No, don't apologize. I just thought if it ever got back, I'm misrepresenting. So I'm really thrilled to be here today, and I'm really, really thrilled to see this series happening. I think all of you, I'm so glad that you're joining us today and recognizing that we've all had many, many Zoom meetings, and it takes, I don't know about you guys, but it takes me some effort now to get myself up to attend one. I think this series will be particularly interesting and wonderful use of that medium. So I want to thank the organizers for identifying the need and for bringing to life this series on methods for global health equity. This webinar series, of which this is the inaugural event. And when I look at the topics that we're going to be talking about over the next few months, I know that there's a lot to be learned and important debates to be engaged in, reflections to be made, and new ideas and approaches to be identified. So as we improve our education on how to carry out this research, we're going to be better positioned to produce knowledge and to use knowledge that promotes more equitable health at home and abroad. And I think these are the kinds of initiatives that efforts that universities ought to be engaging in, and they're of tremendous importance and tremendous value. So I think this is a great initiative. So I hope that this series of workshops sets you on a path where you feel increasingly comfortable with the skills in your toolkit and empowers you to ask better questions and to answer them more effectively. And as you know, the methods we choose to use or not to use can help uphold and perhaps can undermine the efforts to be equitable that are at the heart of this work. It's become I become acutely aware of this as I have been engaged in thinking about Indigenous knowledge and Indigenous methods and the methods that we use that will can promote or undermine equity. I think it's really important that we be thinking about that. I encourage you to reach out to colleagues and to challenge yourselves as you work through these questions. And we at Western are really proud to see the concepts of health equity cutting across the work in many faculties. And we're proud of the inherently collaborative nature of this work with partners in London and around the world. And I think this is particularly exciting as we're engaging in a strategic planning process where we will be identifying our priorities as an institution for the next period. And I would very much like to see our work in global health equity as being part of those priorities. At a time where global wealth disparity is rising at an unprecedented rate, the questions you ask and the solutions that you help provide are going to take on new importance. So I'll turn it over to the next person on the list. And thank you for the invitation for being here.
Thank you so much, Dr. Burkell. And yes, Charles Larson will say a few words as the National Coordinator for the Canadian Coalition for Global Health Research. Charles.
Yeah, thank you, Elise. I will be brief. On the behalf of our 30 institutional members and over 500 individual members of the Canadian Coalition for Global Health Research, I'd like to welcome all of you who are attending today. This is an incredibly important topic, and it's one that the coalition and Elise and others have played an important role over the past decade in better understanding what we mean by equity. And then, as Elise just pointed out, it's that understanding of how we practice, not to what we do. And this is a very much a learning exercise. What you're going to hear over the next couple of months will be dynamic. When we return to this topic, and I hope Elise does this again in the future, you will find that our thinking has advanced. So we learn together. We will make mistakes. We do live with that colonial past that we're all part of, and the privilege that we have that we enter into global health endeavors with. And you literally always have to be on the guard. I find daily, not daily, but almost daily, I find myself stepping into an arena where I think I've stubbed my toe. And I haven't always been cognizant of the equity issues that are in the room. So once again, I welcome you all. I'm really looking forward to this first session, Elise, and thank you for this opportunity to speak on the behalf of the coalition.
Okay, well, wonderful. Thank you so much. And we know that everyone here is very eager for this session, and we have 4 speakers today. So Liana Matthew, one of our students at Western in Health Studies, is going to present our speakers and hand the floor over to you. You'll be able to put questions or comments in the chat, of course, throughout the session, and we'll be taking note of those and pulling some up. There'll be a Q&A at the end. So thank you, everybody. Go ahead, Liana.
Hello, everyone, and thank you, Dr. Larson. For those of us that just joined the webinar, hello and welcome to session 1 of a 5-part series titled Methods for Global Health Equity. My name is Liana, and I am a 3rd-year student at the University of Western Ontario studying medical sciences. I'm part of the CCGHR chapter here at Western, and I've been working closely with the CCGHR team and with Dr. Nouvet to bring together very knowledgeable and distinguished professionals in the field of global health to speak during this series. On that note, I'd like to introduce our speakers for today. So first, we have Annette de Jong from MSF Amsterdam. Annette has been a health promotion and community engagement advisor since 2016. She has a background in nursing, specializing in HIV and pediatrics. She holds a master's in international public health and foreign affairs, and has been involved with MSF, working in countries around the world for many years, including Sudan, Bangladesh, and Chad, to list a few. Next, we have Elia Ormel from McGill University. Elia's work focuses on understanding affected populations and staff experiences in humanitarian crises to improve care. She has extensive experience in participatory research in humanitarian disease outbreak responses, evaluating the implementation of the participatory health promotion strategies, as well as using applied social science research to understand patient and staff experiences and improve healthcare. Next, I'd like to introduce Manaf Abdullah. Manaf is the Health Promotion and Community Engagement Activity Manager in the Iraq Mission OCA. Manaf is interested in using community engagement and storytelling as a strategy to access targeted communities and convert health information into a more community-oriented topic. Our final speaker for today is Jess Richards. Jess is a South African filmmaker and e-learning designer based in London. She's a director of Versafilm projects, and she's passionate about improving access to education and developing innovative digital content through collaborative and participatory design practices. So those are all the great speakers we'll be hearing from today. One last thing before I hand it over to the speakers, as Dr. Nuve mentioned, if you would like a certificate of attendance in today's webinar, we do have a quiz which will go live after today's session, and it'll be up for 48 hours. So once it's completed successfully, we will send you a certificate of attendance, and that will be sometime over the weekend or early next week. I will also input the link of the Google form, which has the quiz in the Zoom chat, so feel free to complete that once the session is done. Okay, and on that note, Annette, the floor is all yours.
Thank you for the introduction. So, can everybody see the slides?
Yes.
Yes, okay. All right, storytelling is how we make sense of our world. Yeah, we all tell stories. It's how we share emotions, experience, both in telling and listening to them, allows the health promoter to better understand the human suffering, its root causes, and it provides him an understanding how communities and function work and how to work more effectively with them. During our Story of Change approach, we listen and catching stories from the community on their perception, experience, beliefs, and myths around the topic or around the disease. Here, how are which people are playing an important role in the decision making? Who are the influencers? And finally, together with the community members, we co-create the health promotion stories in which we share information on prevention, treatment possibilities. These stories went contagious. They went viral and traveled far. They changed the behavior of the healthcare workers and of the community members, and it changed me. First, I would like you to hear a part of our story we co-created with the community members in Nigeria.
Family compound where she lives with her mother, father, and his 2 other wives. Asia is worried because her brother is crying a lot. Last time Mariah saw him, his mouth was swollen and his gums were bleeding. Mariah had told Ababukar's mother to rinse his mouth with salt water, but now she sees him again and he looks terrible. His cheek is starting to fall off. Mariah is afraid the boy has Zayarbagi, also known as Noma disease. She has seen Noma before. It develops quickly and Abubakar needs to be treated straight away. She tells his father and mother about the Noma Children's Hospital in Sokoto. Abubakar's mother does not want him to go. She takes Abubakar to the traditional healer who gives him a home remedy, but it doesn't work. The healer tells her boy is suffering from Masidanwawa, the dumb disease. The dumb disease resists all medicine and does not want to go in. Abubakar's father discusses the problem with the head of the village, the local imam, and the traditional healer. The imam preaches in different villages and has seen...
Maybe we can go to the next slide.
Yes.
Okay, as you could hear in the story, MSF is providing specialist treatment and reconstructive surgery for patients suffering from Noma in Nigeria. And the MSF Health Promotion team sensitized communities with active searching out for new cases. Noma is a horrific neglected disease with mostly affected children under 5 in poverty and poor health. It starts with bleeding gums and then spreads rapidly through the face, causing severe disfigurations. Although Noma can be prevented and treated with antibiotics, more than 90% of Noma patients die because they don't get to healthcare in time. A healthcare tragedy that could be better understood if you literally sit down and listen to their stories. We found that there is a lot of stigma around Noma. Noma is associated with evil spirits, and children are often excluded from their families and social village life. They've been hiding away. And after the children were painstakingly identified, it took a long negotiation process with the family to convince them to access our medical services. And that was the reason we wanted to use the story of change approach to help people to recognize and prevent Noma and to timely seek healthcare. We anticipated that the story would travel to places where outreach workers cannot go and to reach all the patients who are suffering from this disease. Next one. Next slide, please. So here you can see how it works. On one side, you have the local community lived stories, the myths, the beliefs, the experience that the communities have with this disease, with the Noma disease. Then on the right side, you have the biomedical information, the facts and the health promotion messages. And then in the co-creation, we try together with community members, we try to combine these two stories and put it together in a co-created story, what for everybody is understandable and acceptable. And then these stories will be shared with key community members who can spread that in their social network. That's spread. It's surrounding, and the village is far away from the main roads. No school, no telephone, no internet network, and most people, especially women, never ever left the village. And then the MSF car arrives. All men and children run to the car to see what's happening. The health promoters jump out of the car with their flyer and their poster about Noma. MSF health promotion is frequently involves one-way communication with communities, lecturing about the Noma disease. Heard of MSF? No. MSF story members get an understanding of people's experience and perceptions by listening to their collected more than words, local names for Noma, beliefs, local treatments, and so on. We now had a much more better understanding of the community's perceptions, knowledge, and experience. For example, midwives have an important role in signalizing they can move freely between the family compounds in the village. Grandmothers play an important role in care, spreading the news and organizing community support. Noma has many different names like evil wind or disease that doesn't cure. Treating Noma is a community effort. Step 3. After we have this information, we went to the co-creation with key community members. Together, We sit and we try to combine the medical information with the local narratives about the disease. We decide on the main character, his challenges, the support, and the good outcome. This was the creation of the final story, the story of Abu Bakr. Next slide. The health promotion and key community members are now using the spread of the story in the community. Through observations, recordings, and medical data collection, we found that after weeks of telling the story of Abu Bakr, it seemed that the story was traveling. More patients were making their way to the clinic. Between January and August 2018, the report showed an increase of patients being identified with NOMA. So you can see on the blue blocks that are the medical surgical interventions, and the yellow line so in May, in May they had 6 patients. Sorry, in February they had 6 patients. Before May they found 21 patients, and August 28. Similar, we saw an increase of numbers of referrals from key community members. That's the gray line. 67% of the patients mentioned that verbal information shared by their relatives, neighbors, and friends, and were the key informants of the NOMA servants. But even so important was the change we saw in the behavior of the health promoters. Instead of lecturing and a standard message, they were now rolling out their mats and exchange stories with the community. People felt connected to the stories. They were retelling the story to others and shared the story to brought children like Abu Bakr to the health promotion staff to check. Observers reported it was easier to take patients to the hospital with less discussions and negotiations than before. Go to the next speaker, to Ilya, to tell her about her experience in Congo.
Thank you, Annette. So I worked as a health promotion manager in Congo, responding to the Ebola outbreak. And for me, this was the first time I tested or implemented stories of change approach. I'll give you an idea of how it went in Congo with Ebola, or well, in the end with cholera, but I'll get to that, sorry. So Ebola broke out in Congo in August 2018, and MSF's emergency team set up an emergency response in Goma as well, which is kind of the bigger city in that area in Congo, and stayed there from September 2018 to June 2020. It was a kind of a response before the Ebola had reached there, because there was a lot of anticipation that Ebola would rapidly come to Goma as well, and then it would really break out. In the end, there were only 4 confirmed cases in Goma, but the treatment center still treated a lot of people, suspected cases. So in Congo, it's a complex context with many security issues. Oh, sorry, I'm just going to the next slide. Yeah. So MSF, of course, in the Ebola outbreak in West Africa in 2014 to 16, there were a lot of lessons learned, and MSF made a lot of changes in their response. So the Ebola treatment center was very differently constructed. People were able to visit patients that were admitted to the CTE with a 2-meter distance. There were windows where people were treated, and there was also, for example, a little room where people could see their deceased people and see how they were put in the body bag, etc. So there was much more focus on a patient-centered approach, and also more on sustainability and handover. And part of this Ebola response was a health promotion team that would go to the community and reach out. And also there was a big emphasis on being more participatory and collaborating with community members. So, and part of the MSF response was also to assess the needs. And because there were so few Ebola cases, there was also a lot of discussion whether we should respond to other illnesses or other needs that were higher than the Ebola needs. So there was a high prevalence of measles, and there was also a risk of a new cholera outbreak. And MSF decided to rather to only inform people about Ebola, to also respond to the measles and the cholera outbreak as part of the emergency response. So I will speak more now about the health promotion team's response. So there was a big push to be more participatory. So we, for example, now developed the materials together with the team and the communities, the information materials. There were information sessions together with community leaders. So there was collaboration with the community leaders. And the promotion teams, after each session, also asked feedback from the communities. So they asked them how they could improve their work and what the needs were of the community. And there was an effort to make the health education sessions more interactive. So the health promoters would ask people questions. They would ask, for example, what are the symptoms of Ebola or cholera? And then people would be able to respond. So there was an effort to make it more interactive. But it still remained a challenge to move away from this kind of information dissemination approach where people tell the messages about the illnesses. So even though there was all this effort, the team still kind of used the more traditional health education approaches where we share biomedical information, such as how the diseases transmit, what are the characteristics of the symptoms, etc. Even though in health promotion, it's very well known that information alone doesn't help people to change their behavior. There are many different aspects that influence how people make a decision to, for example, increase their hand washing. It might be emotional, it might be hearing from other people's experiences about the illness. So in the end of this, the Ebola kind of response, we prepared the Stories of Change approach, and we decided to focus on cholera because the general mission that was going to stay in coma had a cholera program. So we set up a training with the health promoters from the Ebola team, and we organized a training for the Stories of Change approach. So we had 8 participants, 3 men and 5 women, and they were all very experienced health educators who had been working for a long time in the field. Some had some experience with qualitative research and recording, and we trained at our MSF's main office, but the data collection was in 2 villages. They were about 30 to 60 minutes away from the main office. And we had some health promotion supervisors who were the co-trainers. So in the 2 neighborhoods, Kisiba and Mukungwa, we, after the training and the preparation about how to record and what for questions to ask, we all prepared that together with the team. We went to these 2 communities to collect the stories. So in total, with these 8 people, we formed teams of 2 people, and we collected 24 stories. So we did a data collection in houses and schools and in the cholera treatment center. And in this little table, you see an overview of how long the interviews were. So you see that many of the interviews, so 13 took between 1 to 5 minutes, and then a few more interviews that are a bit longer. And it was also interesting to see that one team had the longest interview. So these 6 interviews were mostly from one team. And in these pictures, you see one family that is being interviewed by one of the health educators. So you can see that the interviews with cholera, and it's something I also saw in Haiti, were quite short, and it's hard for the team to kind of adjust to asking questions differently. And also, I think with cholera, people are so used to receiving certain messages that their story tends to be a little bit the same as well as what they have been receiving from the past. So it requires some skills from the interviewers, I think, to probe people and to ask a little bit more about their experiences. So the teams then developed together with the community, they developed the stories. I didn't have the intention that you can read the stories, but I just wanted to highlight some of the teams that came up, because there were 2 teams that developed a story independently from each. I found it quite interesting that they came up with similar kind of storyline. So they discussed the symptoms of the cholera, Then they speak about local remedies that people use. And everywhere a little bit in the story, you see people reaching out to neighbors in the story or to family members. And then at some point, the sick patient arrives in a healthcare system, and they describe how people, what kind of impact it had of being sick, that the children were at home and they didn't get food, or this kind of stories. And then they introduce good hygienic practices, such as washing your hands, drinking clean water. And then in both stories, the main person also continued to inform the community. So they followed kind of a similar storyline. And then as a feedback from the training participants, that after they developed the story, the health educators went into the community and told the story to community members. And then we had a short evaluation after they tested the story. So they basically indicated that it was really interesting and practical, and it used a method that was new for them. But they felt they needed a little bit more time for details and theories to understand it well. And it's true that the last few days where we collected the data and then developed the story, we had to rush a little bit through the training material because it took more time than we anticipated. What they saw as advantages from their test was that it could help people feel better at ease, that it was enjoyable and participative and interesting as it plays on the level of emotions, that the experiences helped with behavior change, and they really appreciated that it was real and it's what the participants lived through in the community. And when they told their stories, they had also a lot of responses from the participants in comparison to when they did their more kind of traditional health education sessions. And they also indicated that knowledge doesn't really concern community members, and that this was much better because it resembled their situation. And they felt that everybody felt free to express themselves and to make corrections. So they were a bit concerned about the time it would take, and that they felt it couldn't always be used due to the creation phase, that it took a bit more time. And they were a bit worried that men might reject this method. But when they tested it, they were so enthusiastic that they also felt that, that they really wanted to try it with a group of men as well. So just some considerations from my side. One of the challenges with the team was because we asked so much feedback from the community members, it was sometimes hard to find the right balance, because if you ask people's feedback, you also create a responsibility that you have to respond to what they indicate they need. So for example, they asked for food for the children that were underfed. They wanted access to clean water. And these were things that as MSF we couldn't respond to. So that was sometimes hard to find the right balance and not to create false expectations. It was interesting to see that the quality between the two stories was different. One story really took you into the situation, and it really kind of, you become emotional when you listen to it. And the other one had a little bit less of that force. So it would be interesting to know what is kind of the best story format and contents. And I read some papers that say that if, for example, you speak in the I form, that then it's more appealing for people or more likely to help people change their behavior than not. So there's all these kind of characteristics of a story that can be adapted and changed. And then the team kind of found it a bit hard to find the link between the stage where they analyzed the themes and then where they co-created the story. So it was guided by a story web where we map the story elements to identify repeating and recurring words, perceptions, and beliefs and archetypes. But my question was sometimes, how did they integrate the analysis in the story? Did they also take the data to make the story, or did they just kind of really acted on their own experiences and what they had heard, which I think is also fine, but it's just a question I had after doing this. But overall, it was a very, I come from a very, I've worked quite a bit in qualitative research, and I was really impressed that this could be put into the field in such a fast pace, and we could collect all this data. And in a week, we could have this story ready. That was a very powerful health promotion tool. So this is my part, and I would like to pass the word to Manaf. Oh, sorry, I just wanted to also say thank you to the team who has really made this possible, and all the people in the Cholera Treatment Center, and of course the team in Holland. So please go ahead. We'll hear more about experiences from Iraq.
Thank you very much. Thank you very much, Elia. Now, if we talk about Iraq, Iraq is a country has been through multiple major incidents over the past 2 decades, from war to multiple economic collapses to the internal displacement and ethnic conflicts, and ending up with ISIS attack. This made Iraq a challenging context for a story of change activity, but however, it also made it interesting, where the community is a bit conservative, but has a lot to share. In Iraq, to the next slide, please. In Iraq, we have 2 projects with the MSF OCA. One in a city called Khanaqin, and the other is in a city called Kirkuk. We had similar activities from non-communicable diseases to mental health to sexual and reproductive health and health promotion. The pilot training on story of change was started in Khanaqin in 2018, while we started the activity in Kirkuk in 2019. The community in both projects are different, but they have 2 similarities. One of them is that they have high stigma in topics related to mental health issues, and also they have been through a lot of traumatic events, and this affected their ability to share experiences or challenging stories with other people. And this led us to multiple challenges in our during our activities. Next slide, please. Some of these challenges was opening up to others, which meant that the targeted community was not an open community when it comes to sharing emotion, and it took us quite some time to some time to trust people, and this took us a lot of effort to gain their trust and help them to open up with us in their events. And another reason for this was that most of their incidents or difficult experiences they have been through were related to authorities or related to armed groups that still present in their area, which made them like a bit skeptical to share these experiences with others. A solution for this actually was that the community is the health promotion team was a part of the community, and they have been working there for around 2 years before we start the training, which helped us to build the trust with the community a long time before we start the training. So we tried to take advantage of this trust and this network building before we do this training. Another challenge was that because our health promoters were a part of the community, they also had their own difficult experiences. And this, when they started sharing, when they started co-creating the stories with the people, that led them to also face the incidents that affect them mentally, and that was quite challenging. Actually, we needed to plan for this because many of our HPs that they were facing incidents that was very traumatic for them. I remember one of our HPs started crying while we were doing training in Kirkuk city, and we needed to stop the training, and we around for 1 hour just for him to calm down and to come back to the training. For this, we had to prepare ourselves and prepare the team mentally for this kind of incidents. Also, we took the HPs are health promoters, yes, and we asked the mental health team to support us with a presence when there is any incident happening or any emotional case happening, that team will be present with us. Another challenge was adapting to local languages. For us, Iraqi people to speak Arabic, but from area to area, the slang and the local terms are different. And this made it difficult for us when people are starting sharing emotions that makes them like express themselves in their local languages without considering that the person in front of them is understanding them or not. This was challenging for us because the language changes from a village to village or from area to area. But we try to solve this by being prepared with the team, with our team. We try to do this by our team preparing like a list of terms that can be used during this session, and also after the session, our team tried to collect the terms that has been used, and this required the team also to map the existence of local languages and terms used in each area. and to understand the languages, the terms and languages used in the area. Some of the lesson learned in the activity was that acceptance of medical messages. It was clear that the people are more willing to accept medical related messages like NCD messages and information that when it comes in form of a story or like a nice setting, more than like a poster or a direct information or a one-way communication. Another thing is the sustainability of the health information. We noticed like after 3 months of sharing the first story that people are still actually talking about this story. They are still spreading the story during their gathering. They are still spreading the information coming in this story, which was very positive outcome. Another lesson learned was bringing people together, because this storytelling was not only a way to communicate with people or a way to spread the messages, but also it was a way for people to find a safe place to share experience and share emotions without being betrayed or without being afraid to share these emotions, because they used imaginary characters. They used incidents that is close to them, but also they used characters that does not represent them, which was very useful for them. And now in Iraq, after around 1 year of using Story of Change, Story of Change actually now is a part of our health promotion strategy and as an approach method to the community and also a way of distribution medical information. We noticed actually a rise of our patient numbers coming to the clinic in the areas we use the Story of Change. The activities, of course, during the last year were affected by COVID-19 because we had to stop our outreach activities, which included storytelling and story sharing. However, now we are back on track, and we are emerging Story of Change in our new activities, such as like living well groups. We are trying to make it into more sexual and gender-based violence groups, which is very useful as an opener for this session. And also we are planning to approach survivors of sexual violence, sexual and gender-based violence in and mental health patient with this Story of Change as an opener for them to as an icebreaker for them to open up with us. And thank you very much. I will move to our next presenter, Jess.
Great, thanks, Manaf. So if we could just go maybe a slide back or two, yeah. So the next step or the next thing we wanted to think about is how do we sort of spread this training to other health promotion teams within MSF. And as you've heard from the past stories and experiences from Manaf and Ilya and Annette, Story of Change is sort of an approach. It's a concept. It's a kind of a list of skills, and it's also a kind of intervention or a series of field work where you're actually creating a practical health promotion tool, which is this, or which are a few kind of stories that you can then use. So the ambition was to create a training that tries to capture all of these things, and that avoids maybe some of the traditional ways of training in the same way that the Stories of Change tries to avoid some of the traditional ways of a one-way delivery of information and information dissemination. So some of the key elements to that were how can we design this more in collaboration with the health promoters, so people who've actually done this training and experienced the kind of the collecting of the stories and the co-creation of the stories. How can we make sure that the training is led by health promotion teams in the field, that you're not flying in a kind of expat or, to go and deliver this training? Another really key point, I think, of Story of Change is that, collecting information and different types of information, you're trying to understand the community's perspective, beliefs, and the sort of very specific local context. And similarly, the Story of Change approach and the outcomes of the training and the sort of engagement with the community are not going to be the same in every context. So how do we create a training that's also has a bit of flexibility and adaptability to the local context? And linked to that, how do we make space for kind of learning about the differences of the application of story of change, and maybe keep a kind of ongoing conversation. You know, feed lessons learned from health promotion teams using story of change to other health promotion teams that will use it in the future. And then finally, I think the idea about, you know, in the same way, a more authentic and accessible and effective health promotion message or story is going to be informed by the, you know, the subjective position of individuals and their own, you know, their own kind of beliefs and perceptions. And can we in some way include these sort of specific lessons learned from different health promoters? Okay, so that's that. And then if you can go to the next slide, the design. So as I think I've mentioned, sorry, you know, that's perfect. The training is a workshop, so it's sort of led by health promotion teams, but it's done in a group. So often online learning, you know, this is sort of is done as kind of self-paced, self-led. You have one learner sitting in a room going through the modules. But what we needed to do is create a kind of digital guide for a workshop that health promoters were going to lead themselves. So we separated the training up into chapters, and they could work their way through each chapter in a linear fashion. And in each chapter, we've got, so I was very lucky. I got to join Annette in Haiti and Manaf in Iraq to support the training, but more importantly, to film the experiences of the health promoters that were doing the Story of Change workshop, and the lessons that they learned during it, so that we could feed those directly into the end training, so that health promotion teams could basically listen firsthand to some of the individual experiences of health promoters who've already done the training. So just briefly, you see Kenson there, so health promotion manager in Haiti, and you can listen to his experience about storytelling and how that was applied, how that could be applied in Haiti. And then you've got the kind of key learning points and messages, which are a sort of a very summarized version, and the exercises. So this includes exercises and activities and then practical field work. So if we could go on to the next slide. Right, so a number of challenges in doing this. I think one thing is to say, you know, in the same way that Ilya's, you know, experience in qualitative research and the long timelines for that, Story of Change is a very fast and quick workshop. I mean, the minimum amount of time you can do it is within sort of 7 days. And there's a lot of information and skills that are included within it. So, you know, things like active listening, how to analyze stories, how to write a story in the end, you know, develop a script, how to do health promotion messaging. And it's sort of in a workshop setting, you have a bit of flexibility and conversation to respond to questions in class, I guess, and also to further explain anything that's not understood, or some of the nuances around, especially something like active listening, self-reflection. In a training like this, a digital training, you can't cover everything, and you have to make some predictions of what are some of the pitfalls that might come up. Maybe the last thing, if we could go to the next slide. Yes, okay, so the next steps, we're going to pilot that training in the field. There is a lot to sort of think through about the analyzing of stories and also kind of evaluating the impact of the story, and that needs to be developed, and we'd love anyone's feedback on that. And then also trying to work out, you know, how to facilitate, you know, this conversation between health promotion teams who are doing the training. Will have written stories and have lessons learned, how to input that into a kind of online community that they can continue learning from one another. Okay, so very quickly, some conclusions on the final slide. There are a few here, you can maybe also read through them, but Yeah, so some of the main ones, so the story of change, it supports this different way of doing health promotion. It really focuses on the new types of information that are held within stories, and also the different way that a sort of focus on stories and storytelling allows health promoters and the community to interact with one another. So it's a conversation rather than this one-way dissemination. It's very cost effective because those stories are then going to be spread within the community. So it has this kind of exponential effect. Anything else I've forgotten? So yes, so the future development I spoke about is just this link between the analysis and the development of the final story, and monitoring its impact. And I think the other points have been mentioned throughout these two presentations. So have a look at those. And that's it. Thanks.
Thank you so much, Jess, and thank you to Manaf, Ilya, and Annette for your great presentations. I really enjoyed listening to each one of you, and I think I speak for many people here when I say that I learned a lot from each one of your presentations. So thank you once again for kicking off our Methods for Global Equity webinar series. We're off to a great start. Our next session will be on February 24th at 12 p.m. EST. And next session's theme will be participatory filmmaking with children with disabilities in rural India. And that's going to be with Tanya Benjamin. Now, before I pass it on to Dr. Nouvé, who will be moderating our Q&A session, I just want to remind everyone once again to complete the quiz that's linked in the Zoom chat to receive a certificate of attendance for today's session. I will post the link one more time. Yeah, so thank you all for listening attentively. Dr. Nouvé, I'll pass it on to you.
Thank you very much, Liana, and thank you so much to Jess, Manaf, Ilya, and I think that, at every stage of our careers in health research, we're trying to find ways to translate, to do work that can really be sustainable, carried on within communities, be collaborative and appropriate to local ways of knowing and understanding and representing health challenges and goals. So totally inspiring. We do have just a couple of minutes. I think that we're going to be able to take about 3 questions, and I'd like to give a chance to individuals who have posted in the chat, but I'll be able to collate the questions for you as well to send after. The first question for Annette from Olusola is, how was the Northern Nigerian community selected? And I think this is a recurring question, obviously, as we do our work. How do you decide to work with that particular community, given MSF's work throughout the region?
Okay, I hope I understand the question right. But I think for us to, it was more, we looked at the place where we have the clinic, and to go first like in a close circle around the clinic. And then we just widen up that circle. And we also looked at the cases where they were coming from. If they were from a certain area, and we saw most children there, that's then where the health promotion teams will go. So I think that were the 2 main factors.
Okay.
Yeah.
Yeah. Thank you. Is there anybody else on the team who? No, we'll let that sit, because I want to get to Mary Nadu's question. She asked a couple of questions. One about the use of traditional birth attendants as HP agents for Annette, but she also is really curious about the issue of men's participation and how that could be a challenge, and how is that addressed, or are there specific strategies that ended up working within that context where men's participation was a challenge?
Yeah, super good questions. I think working with the TBAs, as you mentioned, as you heard maybe in the story, it was already that midwives or TBAs played a very important role in the identification of NOMA disease in the case of Nigeria, because they were the only ones who could really visit the households. They could enter the households quite easily. So after the collection of the stories, we found out that they played such an important role. We did include them in spreading the health promotion messages, and more actively have meetings and sessions with them. I'm not sure if they are part of the HP team right now, but we have that in a lot of our projects. Yes. Yeah. So
yeah.
Yeah, and also the other question was about men's participation.
Yes.
Yeah, that's also a good question. I think by using these stories, we try to also look at what is the role of the men in the storytelling. Like in this Nigeria case, it was quite clear that men were the decision makers, and that you had the traditional healer and also the village leader. They all decided actually together if a child could go for healthcare. So it was never up to the family or to the mother alone. It was a whole village, actually man decision making if the child could go. So yeah, that's also what we learned through collecting these stories, and also then we adapt our strategies on how to involve them better.
Yeah, it'll be interesting. Just for another webinar, but it's interesting to think about how in the training there might be specific considerations and strategies for groups that might be more reticent based on pride, based on gender norms, based on age norms. So really interesting. I just want to get one more question in before we leave for Manaf, because it's wonderful to have his participation, of course, as well. And really important, I think, to underline that vicarious trauma that can happen to those health promoters involved in this particular methodology, especially if people are thinking that this is a fantastic strategy, just being aware that often there can be such a weight with the stories that come. And I'm wondering, Manaf, if this is, if you feel that the mental health supports that are provided and available to the health promotion team, have they been sufficient? Is that at all an ethical concern as this strategy expands to other parts of the world through MSF?
Thank you very much for the question. Actually, it depends how lucky you get first. If do you have a mental health department in your project or not, if you are implementing. If yes, it depends also on the willing of the department to support, and also depends on the qualification in the project. However, in the Iraq experience, I think we got lucky because the team itself was well prepared, was well trained, but also the mental health department with expat and national staff were willing to support, and that was a strength point. So it depends actually on the context you are being. But I think the presence of a mental health person with the team, supporting the team even during the collection of the story, or being prepared for a scenario like that, I think it will be an important asset for this.
Yeah, no, thank you so much, Manaf. And of course, yeah, the context and what other resources are in place is huge. I do need to wrap that up now, wrap up the session rather. And I want to thank our speakers deeply for this incredibly inspiring first webinar in our series. As mentioned by Liana, we have another one on the last Wednesday of February, and for the months after that. It'll be on participatory filmmaking with children with disabilities in rural India next month. So everybody, if you want to turn on your cameras for a minute and put your hands up to thank our presenters, that would be greatly appreciated. And I hope that everybody has a fantastic day. This will be posted on YouTube and on the Canadian Coalition website as a recording. And I hope you can also grab your certificate of participation, hopefully. So thank you very much, everybody, for attending. And wonderful to meet Manaf, Jesse, Ilya, and Annette. Thank you.
Thank you.
Thank you, Liana, as well, and CCGHR at Western. Wonderful work.
For the invitation.
Thank you, everyone, for attending.
Thank you.
Thank you.